Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week's summaries, which this week were brought to you by our authors Aaron Lacey, Samuel Rouleau, Megan Hilbert, Nicholas Srika, Jonathan Brewer, and Clay Smith. Okay, so let's talk first article titled Airway Management of Adults in the Acute Care Setting out of the BMJ. Okay, so this is a pretty good, pretty extensive review talking about most things airway management in 2026, making sure that we are still up to date. Every now and then we cover an article like this, and sometimes there are little changes that can be important. So let's do a quick review of everything intubation for critically ill adults. We're not talking about operating room intubations here. We're talking about emergency room ICU intubations. So let's stay up to date. First, let's talk a little bit about the preparation, what you need to do ahead of time before the intubation itself. So you need to prepare. There are, of course, two types of difficult airways. One is anatomical. And for this one, most of the sort of physical exam maneuvers that you can do are going to have pretty poor sensitivities, specificities. Essentially, the best thing you can do is an upper lip bite test. See if the patient can bite their upper lip with their lower teeth. If they cannot do that, then it's pretty much the best predictor of having a difficult, challenging airway as a result of anatomy. Next, your other kind of difficult airway is going to be a physiologically difficult airway. We're going to talk a little bit about that later in terms of PEs if you're a subscriber. And these are patients that do not tolerate very well being switched into positive pressure ventilation, or as a result of the medications you give them, then they have some hemodynamic problems. In order to make sure that you have done everything you can, there's a little bit of research about checklists. And they're not a bad idea. They have been shown to do some benefit, although I think they're poorly adopted in the emergency room. Now, how about pre-oxygenation? You have to pre-oxygenate before you intubate, and it seems like the best literature is pointing towards non-invasive positive pressure ventilation with 100% oxygen before you intubate. Thank you, pre-oxy trial. That is the best way to pre-oxygenate your patients, and so that, if it's possible, should be the way that you go. After that, how do you place your patient? How do you position your patient? It used to be thought that in some certain circumstances, or even for everybody, that you might want to put them in a ramped position. That is no longer the thinking on that. There's no real evidence that shows that ramping is better. Indeed, there's some evidence that shows that it might be worse. And so you should not ramp your patient during intubation, but just stick with a good old-fashioned sniffing position. Now, otherwise, in terms of optimization, you want to resuscitate before you intubate as much as you can. There's no clear evidence that shows that there's one thing that you should do absolutely every time. They've looked at giving a bolus right before you intubate, and that doesn't seem to help very much with hemodynamic instability. There's not good evidence to show that everybody should be on a little bit of pressors or if that should be done prophylactically either. There's some ongoing trials. So really, you just want to have resuscitated your patient as best as you can before you intubate. Now, how about what you're actually going to do? Induction agents. Now, it's been kind of back and forth between etomidate and ketamine for which one's really going to be the best for critically ill patients. These authors really seem to come down on the side of etomidate here. However, the evidence isn't that good to pick one over the other. Really, we're looking at really big trials to see relatively small differences. Both are very stable agents, but we can see some minor differences when you look at large meta-analyses of these trials. As for the paralytic, well, I think most people are kind of going the direction of rocuronium. However, there's no real reason to think that one is better than the other comparing it to succinylcholine. Now, of course, there are some contraindications to succinylcholine. And you just have to keep those in mind. There are certain circumstances where, of course, you do not want to use them, such as hyperkalemia or the presence of some kind of neuromuscular disorder. But other than that, I mean, both are going to paralyze your patient, so both are going to give you good intubating conditions. But the other question is, should you give the paralytic first? Is this something that we should be doing? More likely than not, it probably is. If you look at the onset times for most of your medications, then your paralytics tend to take longer, particularly rocuronium. And so if we give it first, then we're much more likely that by the time the patient is properly sedated, that they are also going to be more paralyzed enough that it's optimal intubating conditions. This, of course, that we do not want them to be awake and paralyzed, so you still have to give the sedative agent rather quickly, but it might be better, just from a timing perspective, to give the paralytic first. Then, what kind of blade are you going to pick? Of course, video laryngoscopy just seems to be better. I know not all the data is perfect. If you're an experienced direct laryngoscopist, then it might not necessarily benefit you, but really everything comes down on the side of VL being better, even though it's mostly tested in residents and people with a little bit less experience. All the same, VL's just better, guys. As for bougie versus stylet, at least use one of the two. You should not be intubating without a bougie or a stylet, although some of the data mostly seems to favor bougie a little bit. Personally, more of a stylet guy. And then once you've got the tube in, of course, there's a bunch of different ways that you can check that you've done the correct intubation, i.e., not in the esophagus, and you should be using a number of factors. Try not to rely on one sole factor. However, continuous wave CO2 curves, well, if they look right, then they're not going to steer you wrong, really. All the same, though, look at multiple factors. Afterwards, you're going to want to start some post-intubation sedation. Of course, these patients are intubated. That's not a comfortable position to be in, and they're also paralyzed. Try not to over-sedate. That is associated with worse outcomes, but do not hesitate to start sedation right away. But do not sedate with benzodiazepines as much as you are able to avoid them. This is associated with longer ICU stays and even delirium later on. Now, I'm just going to say a word about some of the demographics that they were talking about because I thought they were interesting, and even though I left them for the end. Medical residents seem to have the first try on most emergency room intubations at 52% in most of the studies that we have, and most of these come from academic centers, of course, whereas medical students only get first try in 2.6% of the time, which is fair. These are emergency airways. Anyways, there's still a lot of questions that we'd like to have answered, such as, should we really be giving the paralytic first? Does the choice of paralytic really matter? We could still use some more data on that. How about the choice of a video laryngoscope? Standard geometry, hyperangulated? I'm not sure about that either. What about the size of the blade? There's still a bunch of questions that we need answered about intubations, and hopefully some future research will be on that too. So in a spoonful, intubations are critical and occur often. Things don't change very quickly in terms of the literature, but it's still nice to keep up to date. And then we skip to the third article, titled Using Serious Games to Increase the Implementation of Trauma Triage Guidelines, a Randomized Clinical Trial. I wonder if that was originally the title. I wonder if it was originally something about video games or something about games in general, and then a reviewer thought that that wasn't appropriate and they wanted something more serious. I'm just speculating here. All right, let's talk about trauma triage and why this is important. Apparently, up to 50 to 70% of older adults, so that's over the age of 65, are under triaged for severe traumatic injuries. And this is important because somewhere between 30 and 50% of these severely injured patients will originally be seen at non-trauma centers. And so they need to be appropriately triaged and potentially sent to a trauma center. If you remember your ATLS, then you know that a big portion of it is just deciding who needs to be sent out of your hospital pronto. And so, what was their plan here? Their plan here was for people to play a kind of video game, which they called Night Shift 2024. And they wanted them to play it for 2 hours and then another 20 minutes per quarter, with the goal of what they call recalibrating physician heuristics, which is really just a fancy way of saying educating people on which patients actually need to be transferred to a trauma center appropriately. From screenshots of the game itself, it looks pretty rudimentary. You're not running around in a 3D, role playing game kind of thing. No, you're looking at some 2D shots of some pretty simply animated characters. And I guess you just have to make some decisions as for who is appropriate to triage where based on the clinical information of that patient. That's just from looking at the screenshots, though. I didn't get to play this game. Now, what did they actually find? Well, the game reduced the proportion of under-triaged patients who were severely injured elderly patients with an absolute difference of 7%. And that's pretty good. I'd say that's pretty good. They did not change the rates of over-triage, though. That was stable. But they did show that there was a dose effect. So if you played more of the game, then you triaged more appropriately. And I find that quite convincing for a true effect level. I like dose effects. There was no change in mortality. So, really, overall, you just have more patients sent to trauma hospitals appropriately, but still more patients being sent to trauma hospitals without a change in mortality. Really, though, I think this is very interesting. This is kind of a novel teaching method in some ways, getting physicians to play a sort of video game. And if it actually results in better patient outcomes, then this is amazing. This is something that's pretty easy to implement, 20 minutes every quarter just to log on and play this kind of game. I wouldn't want to be told that I have to do this by my department, but I love seeing novel teaching strategies. That's very interesting to me. In a Spoonful, video games as a teaching tool were able to make a measurable effect in reducing the rates of under triage of elderly patients to trauma hospitals. It's really nice to see a novel teaching method have a measurable effect on physician behaviors. So let's do a quick wrap up of everything we talked about today. From the first article, we did a review on all things intubation in 2026. Definitely some pearls in there. And then from the third article, a serious, simple video game provided meaningful teaching for trauma triage. This approach could likely be built upon and expanded to many potential uses. And now, if you are hearing this right now, then you are not a part of the members feed, so you missed 3 articles from this past week. What were those articles? Well, we talked about intubating patients who have obesity and what you should do to best optimize them. Then we talked about a reanalysis of the device trial for trauma patients. Is VL still better? And then finally, a retrospective study of patients with pulmonary embolisms and their outcomes post-intubation. Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.